strategic plan. The desired outcome of this effort is a research definition of chronic multiple illness, 1990-1991 Gulf War veterans. VA does not view this as a multi-year research project, but rather as an opportunity to obtain an unbiased evaluation of the information collected and analyzed to date, along with recommendations for the use of the definition in research. And now, to define terms listed in the statement of work specifically provided at that VA provided IOM through Title 38 of the U.S. Code, the Persian Gulf War began in August 1990. It will continue until the date thereafter prescribed by presidential proclamation or by law. But for our purposes, we want to focus only on the health problems of 1990-1991 Gulf War veterans. The IOM shall apply the definition of Southwest Asia theater of operations stated in VA Regulation 38 Code of Federal Regulations. Iraq, Kuwait, Saudi Arabia, the neutral zone between Iraq and Saudi Arabia, Bahrain, Qatar, United Arab Emirates, Oman, the Gulf of Aden, the Gulf of Oman, the Persian Gulf, the Arabian Sea, and the Near-East Footage. From illness and Gulf War veterans means chronic symptom is defined by cluster signs and symptoms manifest in veterans who served in the Gulf War, including pain, widespread pain, persistent memory and concentration problems, chronic headache, gastrointestinal problems, and other abnormalities not explained by well-established diagnoses. That's with law 175. But again, we want to focus on the 1990-1991 Gulf War veterans. The scope of work outlined for this project is summarized on the next 4 slides. We expect the IOM to assemble a committee consisting of scientists and physicians with expertise with experience on chronic multi-symptom illnesses and expertise required to achieve these definition objectives. And, of course, we see that's already been done. That committee is expected to comprehensively review, evaluate, and summarize the available scientific and medical literature regarding these definitions for chronic multi-symptom illness among 1990-1991 Gulf War veterans. Develop the best extensive definition for the chronic multi-symptom illness in 1990-1991 Gulf War veterans. Doing so, the IOM is expected to look broadly at relevant information, include but is not limited to the things listed here, review of published peer-reviewed literature concerning existing case definitions for chronic multi-symptom illness among 1990-1991 Gulf War veterans, published peer-reviewed literature concerning existing case definitions of multi-symptom illness among similar populations such as allied military personnel, review of published peer-reviewed literature concerning case definitions for other populations with similar constellation of symptoms. And we view the next 2 bullets as key parts of the process for IOM. Discussions with researchers involved with developing case definitions for chronic multi-symptom illness. We see that this step will begin with the discussion with members of the VA's Research Advisory Committee on Gulf War illness in the later panel. Discussions with clinicians who treat veterans of the 1990-1991 Gulf War. We're also glad to see that there's a panel of clinicians who will address the committee this afternoon. Additionally, the committee should not feel limited to just these items for information. As I've indicated, we expect the committee to evaluate all available data and routine it. As given in the statement of work, we have a more detailed listing of kinds of information VA expects to see in the report generated from this project. In the final report, which is due no later than April 30th next year, IOM shall establish a consensus case definition of multi-symptom illness for 1990-1991 Gulf War veterans, along with guidelines for its use. Evaluate existing case definitions for chronic multi-symptom illness in 1990-1991 Gulf War veterans in relation to priorities identified by the committee, and determine whether an existing case definition is adequate, an existing case definition needs to be revised, or a new case definition needs to be established. currently a number of case definitions are in use by researchers, and the choice of case definition is left to the researchers conducting the study. This leads to the problem that some states are not prepared because of different case definitions and different inclusion exclusion criteria. Third, consider issues such as specificity, the degree to which the definition applies to 1990-1991 Gulf War veterans. Sensitivity, the degree to which the case definition captures the excess mortality of 1990-1991 Gulf War veterans. Reliability, the degree to which veteran symptoms are determined in a consistent manner. And portability, the degree to which the case definition is suitable for use in different study designs. In evaluating these definitions. The next slide is simply a continuation of that one. Consider the potential for the case definition optimized for research purposes to be used in clinical practice. Consider other case definition characteristics that seem appropriate. Recommend additional areas of research or study that may be required to more adequately develop a case definition for chronic multisymptom illness. 1990-1991 Gulf War veteran. The VA is interested in knowing whether the IOM suggests that more research be done in this area. And finally, evaluate the terminology currently used in chronic multisymptom illness. 1990-1991 Gulf War veterans and recommend appropriate terminology for chronic multisymptom illness. 1990-1991 Gulf War veterans. Be helpful to all parties involved in research if this term could be used to designate chronic multisymptom illness from 1990-1991 Gulf War veterans. So as you've heard, we're first and foremost interested in a case definition that can be applied to veterans of the 1990-1991 Gulf War. VA recognizes that the census case definition might be useful to describe and treat other veterans. The purpose here must be on the various case definitions that have been developed studies of 1990-1991 Gulf War veterans. VA is confident that the committee will be able to evaluate the data presented in person and available in the literature to make recommendations on evidence-based case definition of 1990-1991 Gulf War veterans, as outlined above. The final three slides list the references submitted to the IOM as a starting point for reviewing existing case definition. Of course, this is not exhaustive, and we know that additional relevant articles have been published in there. So, thank you.
Well, first of all, thank you for including me on the agenda at the last moment. On the original, thank you, Dr. Shankar, introductory remarks, because I think you very directly stated the charge of the role of the committee, and I'd like to thank all the committee members for especially volunteering your time to take part in this very important effort. I had the honor and pleasure of attending the last meeting of the RAC, which was, I believe, last week in D.C., and was very quickly brought up to speed on a lot of the science, both a lot of the issues that are involved here. I actually asked to come and talk because I wanted to make sure that I convey to both the committee and to the interested parties where VA stands on all of this and what we expect to get out of it. So the first is to just come very bluntly and put on the table that VA's perspective comes today from the 2000 Institute of Medicine report on Gulf War, and that we as Vic said in his slides, that we agree that this is a chronic multi-symptom illness unique to this cohort of Gulf War veterans as a diagnostic entity that affects about 250,000 Gulf War veterans, is clearly associated with their service in the war. It cannot be ascribed to any psychiatric disorder, and that Gulf War illness likely results from their blend of genetic environmental factors. Also acknowledging that in prior studies, prior reports, we've not been able to provide sufficient evidence to find any specific environmental exposure as etiologic, and likely there are a number of components involved in this. So just to be very clear, VA does not report that this entity described is either inherently nor uniquely a derivative of stress or purely like psychiatric condition. I think that's an important statement to get out on the table. And also, I am extremely encouraged, and we are very optimistic that new approaches are beginning to define specific biomarkers that might contribute to a much more concrete definition of this illness. I'm going to take that as a stepping off point to introduce myself as I did to the committee last week. I am, as you heard, the Principal Deputy Undersecretary for Health. My prior position in VA was that of the Head of Medical Surgical Services, and prior to that was as the National Director for Cardiology, which basically tells you most of my background. I think a couple important things to know is one, that is I still do take care of patients. I have a clinic down in Richmond on Friday afternoons, and I'm very much engaged in the clinical practice. Secondly, that prior to going to medical school and going to have a PhD in biophysics, was at the front edge. There's a lot of work that emerged in systems biology. I have a long history of both basic research as well as in clinical research, and through the past several years working on clinical practice guidelines. And much of my current clinical research has been in biomarkers and cardiac markers. So this is an area very familiar to me. I was asked to get involved in this by the Secretary because I could come to this as an honest broker, having not been prior engaged in much of the work around here, and I will, as I said to the committee, that my intent is to be true to science. I think we need to define the science as best and absolutely best as possible. Cardiology amongst all specialties has been the one that I think has really led the field of medicine in evidence-based practice, and I think we can be as true as possible to those tenets as we move this forward. The task force priorities that you've heard, I think, really outline the intent of where VA wants to be going with this. We believe we need to have a clear understanding of clinical care and the ability to leverage what we know and put that into clinical practice. That means both how we manage and monitor clinical education and training. As I'm sure everybody in this committee knows, the translation of clinical research into practice is not an easy process and often takes many years. The interesting thing about the Veterans Health Administration is we don't just provide health care, we provide a broad base of social services that we believe are inherently necessary to engender good health and well-being, and that ties back into the Veterans benefit component of the Veterans Affairs. Outreach is very important to us. We are constantly striving to do this better, and that includes both getting the word out, but also listening and accepting feedback and changing where necessary when that feedback indicates you're not being responsive. I think we've done a remarkable job of moving in that direction. We have learned over the years that we can't do things by ourselves. We have to work in partnerships. Your being here is as a part of that. We're working very closely with DOD. The President had trusted the Secretary of VA and of Defense in his first year in office of developing seamless electronic records and a virtual lifetime electronic record really to tie together both the service of active duty service members, where they were, to their later health issues. We find this incredibly important, and in fact, if you were to do, I think, a review of everything we know and have done about Agent Orange, you really can understand the problems that could create when you don't know the details of exposure in military history. We take research very seriously. As you heard, we have a very well-structured and well-regarded research program. We fund intramural research only to the tune of about $600 million a year, and the collective responsibility of the research. The head of research and development is to the tune of about $1.3 billion a year, and that's conducted through researchers at the VA and those with academic affiliation. So why a case? And first of all, the big question is why now? It's been 22 years since the war, and I think the answers are intuitive in what you just heard in the charge to the committee, that in fact there are multiple case definitions, and this is creating because of new research coming out, frankly, by methodologies that were not available even a couple of years ago. New things in the world of imaging sciences, for instance, understanding of biomarkers, proteomics, and many metabolomics, others that I think and hope really will bring promise to this field. So moving that forward is really going to be dependent on having a unified case definition. What are we going to do with that knowledge? And there's a couple things that are going to happen. It's going to get tied back to the benefit side, undoubtedly, but most important, the value of having a marker that can predict or tell you something about a disease is also the ability to understand how to treat that disease and how to monitor the effectiveness of it. So that fundamentally is where we're going. There are going to be questions about changing compensation. That is a discussion that will happen at the department level, particularly with the VA, Veterans Benefits Administration. But simply said, the better the case definition, the easier it is for readers to make those determinations. So because I have 2 degrees, I'm allowed to lecture. For everybody on this panel that knows this, but I know there are people out there that don't. And I want to talk, and particularly because of the world of biomarkers, this notion of the receiver-operator characteristic curve, because I think this is going to be very important in the work that looks for. So when we look at biomarkers, we know that there are 2 things that are important. One is how sensitive is that marker versus how specific. And the ROC curve plots the sensitivity against 1 minus the specificity. So what that would say is the further you are to the left side of the curve, the more specific you'll be. The further you are to the top of the curve, the more sensitive you will be. So a test that would essentially be random would be a focus point, and that's that straight line, that horizontal straight line. We generally judge the value of a test, and there's great arguments in the laboratory medicine world about the value of all the other things like coefficient of variability, for instance, versus the simple area under the curve ray you see when looking at a new test. We see as a proportion, so that horizontal line would be 0.5, and in the perfect situation it would be 1, and a curve like this would probably be somewhere around 0.7. What we'd really like to test would look like this, that are very highly sensitive and very highly specific. That's not what happens in most cases. There are some that do, and if we could have 2 curves that look like this, I'd love to be the one to have to argue the difference between the 2. It's not be a hard problem. This is what we usually look like. And so when we start talking about case definitions, if we were to plot these as ROC curves, we would see a number of different curves. And you can see the lower side of that curve, the 4 or so that are bundled in there, are ones that probably don't have a whole lot of value to us. As we get further to the top, we get more and more looking at a curve like what we would like to see. And that means as you push them to the left, we get the better specificity. To the right, you get the higher, toward the top, you get the higher sensitivity. This is what kind of curve we would like to see. And the real question is, what are we going to do? What's going to take to get to that area? And so I want to be very clear, and the reason I put this in is I know that the charge to the committee talks predominantly about reviewing existing case definitions. I do want to be clear that you are not tied to that, and whatever new data is available that can help push that curve, push an ROC curve towards a more sensitive and more specific definition, then you should do so. And I put that on the table because at the end of your initial deliberation, if you feel that the charter does not allow that to happen and we need to rediscuss that in any way, then we are happy to do that. I also put it up because I think there's an important issue here, and that is in the charge of the committee, it very specifically talks about a research definition. And when we're talking about research definitions, we tend to weight this curve toward specificity. When we talk about clinical definitions, particularly when they're tied to involvement in treatments, and particularly in the case of veterans where they may be tied towards benefit, we may be wanting to weight that curve toward sensitivity. It's always going to be a trade-off, but I think we need to have a discussion, particularly as you hear from other members of panels today, their opinions about the weighting between sensitivity and specificity of the definition. I think that's going to be a very important part of the deliberations of this committee. So the question is whether information is needed. As I said, there's just in recent months, there's new information sensitivity is most important for research. High sensitivity is most encompassing for ascribing disabilities and benefits. Ideally, we can have both, but that may be a difficult choice that needs to be made. Again, the charges for research definitions, because I think at the front end, driving tests and diagnoses is probably the more important, but giving consideration to the others are important as well. So I'll close, and I think for questions from the panel, but I again want to be clear. We are committed to doing this. I have been asked to get engaged in this, to be the honest broker between science and the needs of the veterans. I committed to the RAC, the Research Advisory Group, that I will do that. I'll commit to you here that I am there to do that as well. If there are issues that come up, I am at your disposal. And Dr. Agarwal will be joining me in that. She couldn't be here today, but she is the Assistant Deputy Undersecretary, the Deputy Undersecretary for Policy and Programs, and it's the direct line of authority over both the ORD, Research and Development, as well as the Public Health Board. So between the two of us, we will be at your service if there are questions and issues that you need to discuss. I'm very pleased that you have this open session today. I very much hope that you're all in listen mode. And again, after your deliberations tomorrow, if there are things that need to be discussed, again, I'm at your disposal. I'm glad to do so. So we're glad if you've got time to take a couple questions.
Actually, I'm Bob Yeager, Director of Deployment Health in the Office of Research and Development. My primary today here was to back up to Dr. Callison's in case he got laryngitis or something like that. I did want to just mention one thing. There were several hints in presentations about our collaborations with the appropriate to the Department of Defense, and that's one of my primary roles when I was selected for this position. So over the past almost 2.5 years, or three almost, I've been working hard to build collaborations with DOD, and to the extent that anything comes up where anyone thinks DOD needs to be involved in this, I perhaps help out with that. I want to close, I think, speaking part of this presentation by thanking everyone who came here today. Of course, the committee's already been thanked, but we have a lot of people in the audience, and just want to thank them all for their interest, and I'll stop there.
A couple of just questions. Dr. Kalatinsky, it would be very useful if you give us a bibliography on, which included, I presume, the 10 different definitions you've used. It would be very helpful to us if we could actually see what you interpret to be the 10 definitions. We're looking at a variety of definitions in a variety of literature, and we want some way to easily display what we're talking about in terms of those 10 definitions. The corollary to that is that I think the committee has interpreted its charge to mean that it is responsible for the best definition to come up with, independent of whether it's similar to the same as or quite different from established definition. I think we understand that as our responsibility.
The references are that list that was on the final slides, and in the next statement of work, the reference
I understand the papers. The question is what in those papers constitutes, in your view, a definition, and how you have it interpreted as we've used the term 10 definitions. We're just interested because we're looking at what we think are definitions in a variety of areas. I'd like to know whether the same definitions that they're talking about.
The definitions that have been proposed differ in a number of different ways, and the way that they were prepared, some stacked analysis, some methodology. We're aware of that definition. Different groups of veterans were studying the different as well. So definitions that, for example, have lists of exclusionary characteristics, exclusionary conditions. So if a patient has A, B, or C, then they're excluded from.
We understand that. We're simply asking what you consider to be a definition that you add up to be 10 definitions. That's all. Some definitions, as you said, list the number of domains and then got to be 2 out of 3 or 5 out of 6. The range of those. If you were to create a spreadsheet of definitions.
Oh, sure.
But we'd like, because we would like to be able to look at that against what we see as definitions. It's just a way of getting this information. I mean, this is just, I think, a straightforward question. You showed us a large geographical area which involves these veterans. When we talk about deployed versus non-deployed, we're assuming that non-deployed are people who are not in any of those geographical areas.
That's right.
Questions from the panel? Please.
I just want to make sure that I understand. On the one slide, you talked about the charge to our committee to find a research definition, which, as stated at the end of your slide, that's certainly focusing mostly on specificity. But if you're thinking about how this definition will be used, particularly at the case of compensation, we talked about how your slide mentioned the importance of rather than sensitivity, rather than specificity. And so I just want to make sure that I'm understanding correctly that we are really trying to optimize both sensitivity and specificity, and not strictly focusing on specificity, which we would do if it was purely.
So it's we want it to be used in research. What we also would like is for that research definition to help clinicians, guide the clinicians, and coming up with clinical people. So
The charge is very about the economic. The charge says, consider the potential for case deposition optimized for research purposes to be used in clinical practice. And so we're struggling a little bit with that. I would also raise, and this is again not to be interpreted as compulsion, but just a question. Is there room for 2 definitions? A research definition and a clinical?
So, I mentioned this because I do think it's going to be a challenge. And very clearly, the charge talks about a research definition, but I think, to my mind, if there are required to, we would certainly like to understand what are the differences that would drive one towards the other. Okay, so as defining the research definition, if it does not fit a clinical definition, so in essence, if you were drawing RLC curves that were widely divergent, it would be most useful to know what drives that difference. And I think as we move through this, a little bit more clarity around it. If there clearly are going to be divergent definitions,